The relation between the degree of insulin resistance and length of hospital stay was already established some 15 years ago or so, in the late 90s. Since the length of stay in a hospital is not a very robust measure for improvement of outcome, more evidence was needed. And some evidence was published since then. The most recent evidence comes from a very eloquent and very recently published study from Sejo and colleagues. By using the very robust hyperinsulinic clamp method to determine the degree of insulin sensitivity, this is also the gold standard, by the way, they compared two groups of in total 273 patients undergoing bypass surgery. One group consisted of patients without diabetes, and the other group had diabetes. This last group was further divided in subjects with a high glycosylated hemoglobin and a low glycosylated hemoglobin. The most important finding, certainly within today's context, was the clear relation between the degree of insulin resistance and the occurrence of major complications, in particular with respect to the infection rate. Moreover, this relation was present independent of the presence of diabetes. And that's crucial, I think. They showed, for example, that a fall in insulin sensitivity of 50% after surgery increased the rate of major complications 5 to 6-fold, and that the risk for severe infection even 10-fold. In this context, it's important to know that upper abdominal operations, normal upper abdominal operations, lead to reductions in insulin sensitivity in the order of 50%. And for colorectal, a bigger colorectal surgery, this may be even higher. This table serves to outline once more the most important metabolic changes seen relating to surgical stress and those related to fasting. The endocrine response, as we know, involves an increase in production of glucagon with a concomitant reduction in the production of insulin. The metabolic responses involve an increase in glycogen, protein, and fat breakdown, while there's a notable increase in insulin resistance. All of these responses are also seen with respect to fasting, causing them all to be exaggerated in the fasted patients undergoing surgery. In short, fasting further increases the effects of surgical stress. So, now that we've shown that fasting contributes to insulin resistance, and insulin resistance contributes to worse outcomes, it seemed logically to investigate to what extent the safe use of preoperative carbohydrates contributes to an increase in postoperative insulin sensitivity and an improvement of outcome. The first study investigating the role of preoperative carbohydrate feeding on insulin resistance studied the effects of IV glucose, 20%. And results were really promising since there was a reduction of postoperative insulin resistance of approximately 50%. And patients showed less protein loss also. However, as you all know, a high glucose concentration results in an irritation of the vessel. So 20% results in a high osmolality and a low tolerance. So the next step was just to investigate whether or not such solutions could also be given orally. To my knowledge, there have been approximately 5 studies investigating the safety of oral intake in carbohydrates. All 5 showed equal or even improved gastric emptying when taken up to 2 hours before surgery or anesthesia. Noteworthy is that most studies investigated the 12% maltodextrin solution. In earlier studies, one determined that a 6 or 7% was not enough, and a 12-13% solution is usually sufficient. Thus far, one has been reluctant with diabetic patients. As most of you have learned, diabetic patients tend to have a slower emptying of their stomach. However, the one study that has been published shows equal gastric emptying as compared to healthy subjects. Moreover, the use of carbohydrates may be of particular importance in this group, since these patients already have a higher degree of insulin resistance. Currently, there's ongoing research with regard to more enriched drinks containing amino acids and peptides. However, evidence with regard to safety and metabolic response is, let's say, incomplete. So we have to wait out the next few years. So, coming to our first recommendation, the current evidence shows that it's safe, even for diabetics, to drink carbohydrate-rich fluids up to 2 hours before elective surgery. Noteworthy is that most studies used the maltodextrin solution, and in most studies, drinks were given along with patient's morning medication. Now, with respect to outcome parameters, it was shown that the intake of oral carbohydrates until 2 hours prior to surgery led to less thirst, restlessness, weakness, nausea, vomiting, and concentration problems, although the extent to which these were reduced differed between studies. Other important evidence for a reduction in insulin resistance, of which we just showed that it impacts on outcome, after the use of oral carbohydrates comes from the studies investigating insulin resistance after respectively hip surgery, colorectal surgery, and laparoscopic cholecystectomy. In all but one big study in cabbage and bypass surgery, which did not show a difference in insulin resistance, but did show improved cardiac function, or in fact less use of vasoactive drugs intraoperatively in the carbohydrate group. The most likely explanation is that the most likely explanation for not finding a difference in insulin resistance in this study was the fact that this insulin resistance was measured with a different method than the traditional and gold standard of hyperinsulinic clamping. Other positive effects that have been observed are an improved muscle mass at discharge and a better cardiac function in the intra and post-operative setting. And finally, a reduced length of stay was observed in 2 studies. This reduced length of stay could not be confirmed in a recent study by Mature. However, I think that the method used in this study may likely to be explain the lack of difference found. So coming to recommendation 2, since the cumulative evidence is largely in favor of the use of oral carbohydrates, we've come to a second recommendation, namely that drinking carbohydrate-rich fluids before elective surgery improves subjective well-being, reduces thirst and hunger, and moreover reduces post-operative insulin resistance. So this brings me to my conclusions. I hope to have made clear to you that the insulin sensitivity, or resistance, if you prefer, is related to the outcome of surgery, and that the insulin sensitivity can be influenced using oral carbohydrates. Furthermore, we think that the evidence points out that the use of these carbohydrates is safe up to 2 hours before anesthesia. Finally, I would like all members of the task force for their nice cooperation, and in particular our chair Ian Schmidt, who did the large majority of the work. Ian, thank you. And also I'd like to thank Professor Olle Lundquist from the Karolinska Institute, who for his contributions for this talk. Thank you.